When you face those problems, you have a couple choices, right? You can say, these problems are too big for me and I can't solve them. Or you can say, these problems are going to persist unless I do something about them. And when you make the latter choice to say, I'm going to do something about them, you then need a skill set to approach those problems.
Hello and welcome to Clinical Changemakers, the podcast that explores vital lessons in healthcare leadership, innovation, and so much more. Today on the show, we have Dr. Kedar Mate. He is a medical doctor and researcher. He is also the president and CEO of the Institute for Healthcare Improvement. So let's begin. Dr. Kedar Mate, welcome to the podcast.
Thank you. It's nice to be here.
Before we talk about your experience at the IHI and your leadership experiences there, I wondered if you could talk a little bit about your early experiences of healthcare and basically your journey into healthcare.
Everyone, I think, has a different way of coming into the field. Everyone's got their own story, so it's a great place to start. Mine, began very early on. I was a kid growing up with both parents, immigrants from India to the U.S. I grew up in sort of central New Jersey. My father was a pediatrician, is a pediatrician, and still practicing now, even into his late 70s. And my mother worked in the hospital as a microbiologist, as a lab, in a laboratory. And so I was around healthcare my whole life. I remember, early days rounding with my dad, on the pediatric wards of the hospital. So I was around it a lot in my youth. But there was also another phenomenon that was taking place, which was that my parents were recent immigrants to the U.S. And anytime they had enough money saved up to make a trip back home to India, we would go back. And I would get to contrast my upbringing with the lives of my cousins who were, a similar socioeconomic class in India, but also everyone around you in Bombay. And the sort of sense of inequity was very obvious, even at a very early age. And I suppose that made the biggest difference in my life, at some level. It wasn't just about medicine or healthcare. It was about this sort of broader set of issues that was affecting people's lives. I knew that was kind of the place that I wanted to work most. Was on that issue of social inequity that was easily observable in the context in which I was having the chance to visit. But whether I was going to approach that problem from medicine or not was uncertain. I studied history actually in college, not the medical field. And the reason I studied history was I was interested in stories of communities as they encountered political systems and other things that would construct their experience of health. And I was writing about Haitians in the U.S. and their experience with HIV infection in the early 80s, late 70s, early 80s. And I came across the work of Dr. Paul Farmer, who, of course, many of your listeners will know. I wasn't even in his university at the time, but Paul agreed. I contacted him kind of randomly. So one thing I'd encourage your listeners to do is when you find somebody inspiring, reach out to them, because who knows what will happen. But I reached out to Paul, and he wrote me back. And we began a kind of friendship over many years, mentorship. He agreed to advise my senior thesis as an undergrad. And I went to work for Partners in Health soon thereafter. And it was there that I, encountered economists, anthropologists, folks, sociologists, as well as physicians, and how they were working in very under-resourced communities. And I realized it was the physicians that I most wanted to be like. That was really kind of the moment, I think, actually much later in my career than I think a lot of people make choices around these things. But it wasn't until after I graduated college that I was like, oh, this is what I want to do.
How did you find, doing an undergrad in history and being around people who were multidisciplinary has sort of shaped your clinical career?
Almost every problem is in life, is whether it's in healthcare or not, is a complex problem, right? Humans make complicated problems, on some level. And, in order to solve complex problems, you often need multiple angles to solve those problems. And some of those you get through partnership and through colleagueship with other parties. I will never be a fully trained economist, but so I need people who understand, in my case, health economics to advise and participate and collaborate on certain things. But I like to say, there's every healthcare problem is multidimensional, and you need as many of those dimensions represented around the table as you can assemble. If you can find someone, or if you yourself can have more than one of those skills or attributes yourself, in your toolbox, then you've got an advantage in terms of trying to find a solution to a complex problem. So, any problem, you think of waiting times in the emergency room. That's a complex problem. It might seem simple on some level, but it involves clinical challenges. It involves queuing theory. It involves reliability science, and those are things, health economics. You need all of those disciplines represented at the table to be able to come up with a reasonably useful solution to that problem. If you can possess the clinical knowledge plus, any one of those other areas, you've got an advantage in terms of trying to solve that problem. So I think, in general, my response to this is that you need as many tools in your toolbox as you can assemble, and then find others who have the tools that you don't have, and build relationship with those individuals to help you solve these kinds of complicated problems.
I love that. I love the fact that you're talking about healthcare systems being, complicated and complex, but also the fact that you're saying that healthcare professionals aren't the gatekeepers on contribution to healthcare. And I think sometimes you can hear a narrative of doctors and nurses are the only ones who are able to contribute. And what you're saying is actually, no, you need a whole multidisciplinary team, and lots of different skill sets can be helpful.
I'll say two things about this. One is that often clinicians are not at the table. Oddly, you've got the business people or the financing individuals or otherwise that are kind of in the background, kind of actually pulling a lot of the strings, and the clinicians and the patients, who are the ones that are really experiencing whether care is working for them or not, are often not at the table at all. So one part of this is, you'd be surprised how many tables are being architected at which decisions are being made that are enormously consequential for how clinicians provide care or how patients experience care, that leave both of those parties out of the decision-making process or otherwise. So again, your ability to have multiple dimensions, if you're training as a clinician, nurse, doctor, social worker, pharmacist, whatever, if you're training as a clinician, to be able to participate sometimes in these tables often requires an additional skill set that allows you to, entry into those environments. And the other point I suppose I would make is, when you're there, there's sometimes when clinicians are at the table, I think you may tend to, not that the clinicians necessarily dominate, but that there's a lot of deference to that kind of expertise. And I think it's in some ways up to the clinicians to invite the other disciplines into the conversation when you're having that, and particularly highlighting the end user or the patient, or however you want to describe that individual, the consumer or the patient, the actually end beneficiary of all of this. That voice, often left out or left behind, is a part that clinicians can elevate in the conversation. Really importantly, use your power to bring that voice in, so that we can hear that voice very clearly in the kinds of decision-making conversations that are often taking place.
Just coming back to Partners in Health, if people haven't heard of Partners in Health before, there's an incredible documentary called Bend in the Arc on Netflix, which I would highly recommend. I just wondered, in your early career, were there any particular experiences in leadership or innovation that shaped your thinking today?
Yeah, absolutely. So it was actually while I was working for Partners in Health. I was based in Peru at the time, in Lima, in a sort of shanty town north of the city called Caraballo, which is a very, it's a peri-urban slum built into this mountainside with rubble everywhere, and not thatched roofs, tin roofed housing dwellings for the people that live there. There was a church and a clinic. That's sort of the environment that we were in. And we were treating multi-drug resistant tuberculosis, very complicated disease, requires multiple medications that are really old medicines, actually, and pretty crude, lots of side effects for those medicines. And the treatment course can last, 2 years or longer in some cases, depending on your response to the therapy. Very complicated, difficult condition. The World Health Organization, WHO, had basically said that treating this condition in resource-limited settings like we were working in was untenable. It was impossible. It had essentially confined those that got the infection to more or less palliative care and ultimately death. Partners in Health took a different position. It said, biology is biology, as so many people have heard Paul Farmer say in the past. And, the biology of the poor and, under-resourced is the same as the biology of the wealthy. And it turns out that when you treat people with care, compassion, and the same medications, they respond the same way that people do in Boston or New York or San Francisco or wherever. And so we took that position and we started treating, patients, hundreds of patients with drug-resistant tuberculosis, anti-TB meds. And they were responding exactly as you'd predict, Jono, with cure rates of in excess of 75%, very similar to the rates that we were getting in Boston at the same time. So we were proving essentially that, Paul's thesis that, biology was biology and that people could get better in this condition if we only, built the programs like we had built to help do that. But we were having a problem. We were in Caraballo, in that place that we were working, we were getting great treatment success rates. And I was, by the way, at this time, I had finished my undergraduate time. I had started working for Partners in Health. And I was a community health worker. I was helping the community health workers do directly observed therapy. I was myself kind of doing directly observed therapy with some of our patients, helping them take their medicines, that kind of work, and writing and doing research with the rest of the PIH team. But we were having trouble scaling this program. We were very good at doing it in the place that we had done it in Caraballo, but other people needed it. We had long waiting times, huge waiting lists to get into this program. People were traveling from all over the country to come to the gates of this one clinic in Caraballo to get this kind of treatment, which was offered nowhere else in the country. And we had no way of replicating the program to other parts. We had tried it several times, replicating in different parts of the city of Lima, in the outskirts of Lima, and elsewhere in Peru. But we had been sort of unsuccessful at replicating the program. And that's when this was another founder of Partners in Health, Jim Kim. Jim Kim and Paul invited one of their colleagues, Don Berwick, to come to Lima. And Don was a professor of pediatrics at Harvard, alongside of Paul and Jim. And Don had been working on systems thinking and how to make systems behave better, how to improve them systematically. And it was Jim and Paul's thesis or notion that maybe the problem wasn't a clinical problem, but actually was a problem of the system that they were trying to replicate this program into in other parts of the city and then other parts of the country. Don came down. I was sort of his translator, if you will, for a week. And I learned about the kinds of questions Don was asking about how systems work through his point of view, his lens. He was asking about what we were aiming for, how to make changes in our system, what were the barriers, all the kinds of root cause analysis. He was doing things that I now do when I talk to people, but I didn't know it at the time, right? I was just doing the duty of listening to Don and translating his questions and translating the answers back to him. And, Don helped us design what became the first learning collaborative, as we called it, learning and treatment collaborative in Lima. We had 41 teams from all over the city who were trying to replicate the Caraballo drug-resistant TB program in their environments. And then we had, very importantly, a Team 42. And Team 42 was from the government, was the Ministry of Health. And the job of Team 42 was to remove whatever barrier was being put in place by the government to prevent the scale up of this program. And so that involved things like changing treatment guidelines. Remember, at this time, this disease was not thought to be treatable in this environment. So the clinical guidelines in Peru said, don't treat someone that you found to have this disease. And so the Ministry of Health had to change that treatment guideline. They had to make it easy for the medications to come through the ports of Lima to be in the airport and the ports to be imported into the country. We had to set up a reference laboratory. There was all kinds of logistical hurdles that the Ministry of Health team had to solve. And so we ran this program several years. To my knowledge, now it was the first learning collaborative that has ever been run in a lower middle income country. And it was wildly successful, not just because of our effort at what was known as the Institute for Healthcare Improvement, IHI, the place that I now work, but also because of the really hard work of the Partners in Health team who were helping to mentor and coach all those places. But that experience, learning that it wasn't just the biology of our patients that was the obstacle to progress and improvement of whole population health, but in fact, the obstacles that governments put in place or that our systems architected to prevent us from doing this very doable project. That experience really was eye-opening for me. It was the experience that I think of as being the sort of transition point in my thinking. To not only do I need clinical skills, but I also need to understand how systems work, and I need to not only develop the skills to treat patients, but also the skills to treat systems. It's that combination of things that became sort of the crucible for me to shape the rest of my career.
The other thing that I'm picking up on is that systems aren't neutral. We often think that the system that we're working in has always been there, and that's just the way things are, until you start to unpick some of the layers and then really understand why the outcomes are occurring.
Yeah, no system is neutral. I think that's a very good point. That there's no such thing as a neutral system. Systems were all built by people, right? And they're built by people. They're structured with our own biases and our own belief structures. We build those into our systems. We replicate them in our systems, and then they absolutely right. They can be improved by people just as well, And we have this. We also have this other. There's this other persistent mythology, which are systems are more reliable than people. And the point is that people build systems, and so that in some senses, systems can be more reliable than people. But they can also perpetuate or increase the reliability of something that prevents, in this case, access to medications that were life-saving. So by changing the premise, by asking a different question, we can create an important innovation, not only in clinical care, but also in how systems behave.
And another piece that I'll just pick up on that you spoke about there was also around leadership. Maintaining core values and principles. If equity is really something truly that you believe in, then you appreciate that everybody deserves high quality care, and it doesn't matter who you are, where you're from, what environment you're in. And I think that's something that I think is quite powerful, is even when you're further along in your career and there's all sorts of different constraints put on what you can and can't do, holding on tightly to the values that are important to you really shapes the kind of leader that you become.
You nailed that, spot on, Jono. I mean, I teach a course now with fast forwarding many years from that that moment 24 years ago now, when I was sitting in that clinic and discovering systems change. But many years from that point, I now teach a course with the IHI fellows, the Institute for Healthcare Improvement, the organization that Don Berwick, who came to visit us in Peru, had founded, that I now lead. That institute has a fellowship program, and that fellowship program is typically for mid-career professionals who are at a pivot point in their career. These are folks that have been leading some aspect of their health system for a long time, and now they're about to take the next step to leading an even bigger part of their system or their whatever they're doing. And one of the course that I teach with them, or the session that I lead with them, is about values-based leadership. And your point is exactly right. We have a tendency to try to change behaviors, to alter a particular behavior. And if you think about that drug-resistant TB program, the behavior, if you will, would be providing a certain set of medications to a poor person, that has drug-resistant TB. That's a behavior of the clinical system in that case. But underpinning that behavior, and whether or not access to those medications becomes possible or not, is a mindset. And the previous mindset had been, poor people can't do this, undergo this treatment regimen. It's not possible for them. And the mindset that we were bringing in that early stage project was, this is absolutely possible. But underpinning the mindset is a set of values, right? And the values in the first model was that, it was essentially a value of inequity is okay, right? This is permissible, that, this is life, that, the poor don't merit the kind of treatment that the rich merit, something along those lines. And the mindset that Partners in Health was approaching this from, and that IHI was approaching this from, is that's nonsense, right? Inequity is unjust, unconscionable, and that equity is in some ways all that matters. That we need to create more equity in the world, and so that value system, helps to shape the mindset then that says actually anyone can receive this treatment and get better from it, which then shapes a behavior, which is let's deliver this medication to these patients in a timely fashion. But without that, the behavior is unsustainable. If you don't change the value system, if all you did was change the behavior without affecting the mindset or the value system, then the behavior will be ephemeral. All the concerns about sustainability of whatever behavior or practice is often due to this primary cause, which is that we haven't actually changed the mindset or the value system that underpins the behavior. So as soon as a new leader comes in, the behavior fades away and we lose the sustainability of that effort. So I often, when we're talking to these mid-career leaders who are about to take on something new, it's don't just focus on the artifacts of the mindset, the behaviors, but you've got to work on the mindset and values that underpin those behaviors fundamentally if you want to actually sustainably change the system.
And I think a feature or a skill set of leadership is innovation, because you need to be able to basically keep up in some sense with this dynamic system. And I think at times innovation can be seen as scary, it can be seen as risky, but I think the alternative is essentially accepting, in some sense, implicitly, the status quo. And so that's, I think, a powerful thing for me to be like, well, what are the skill sets that I need to learn to be to have innovation as one of those things in my toolbox, along with leadership. And of course, at the IHI, you guys are all about that.
The innovation is its own set of skills, right? To be and they're well practiced. So there's a mythology around the creative genius, the Einstein type, where some lightning bolt strikes them and suddenly they've got this great idea. But Edison, I don't know whether Edison ever actually said this, but allegedly said that he failed at making a light bulb. I didn't make a light bulb. I failed at making a light bulb 1,000 times, or whatever number of times he said. And the point of that is that innovation is a practice. It's not a innate feature of a human. Some are innovative, some are not. That notion is nonsense. It's everyone can become an innovator. Anyone can become an innovator with some practice. In essence, it takes a lot of practice. And the most innovative people, like the most brilliant musicians or the most brilliant basketball players, have shot a million free throws, right? And whether Malcolm Gladwell is right about the 10,000 hours or not, I'm not really sure. But the notion is, it takes a lot of practice to be innovative. It takes hours of essentially applying a certain mind frame to problems that you tackle. I think one characteristic of the innovator is to be a little fearless, to not to approach whatever problem it is with curiosity and a certain kind of belief, if you will, going back to values and mindsets, a certain set of beliefs that and values that any problem is amenable to innovation, that you can apply yourself to any problem and try to find a new way with that effort. So I think that is a clear sort of value structure within that. There's disciplines around innovation. There's sort of ways of practicing it. There's IHI uses a methodology called the model for improvement, which is to discern an aim, which is usually driven by a consumer need or requirement, establish a measure so that you can establish whether you're getting to that aim, and then identify a series of perhaps small or big changes to the system that's in play that will allow you to understand or make progress towards that aim. And then you use an iterative learning cycle called the Plan, Do, Study, Act cycle, which is now fairly well known as an iterative cycle of learning. And if I look at all the design methods, the IDEO method, for example, or human-centered design approaches, which are often classically associated with some of the most innovative things coming out of Silicon Valley or where you are at Stanford. These methods, they all have at their core some kind of rapid cycle or iterative cycle of learning that allows you to test very quickly your hypotheses against a stated ambition or a user-defined need. And that is the essence of human-centered design. I think it's worth getting these skills in your toolbox. Again, it's one of the skills you'll need around the table to solve a complex problem. This notion of design thinking or innovation skill sets will be necessary sitting around the table. And I would venture to suggest that they're relatively easy for people in clinical life to get because hypothesis testing and experimentation is native to the clinician, right? So clinicians are readily adept at testing things. And this idea is very fundamental to how we practice as physicians. I'm an internist. So if a patient comes into my office with pneumonia and I treat them on empiric antibiotics that are specific to the local antibiotic sensitivities, I start them on a medication, they leave, they don't get better. What do? I switch medicines to a different medicine, try that for a little while. If that doesn't work, then maybe it's not a pneumonia at all. Maybe it's something else. Maybe it's a chronic obstructive pulmonary disease, COPD, or maybe it's emphysema, or maybe it's something else. Maybe there's what this patient is experiencing wasn't a pneumonia to begin with. And so I think that's kind of at the heart of kind of what we do as physicians, and or clinicians in general. We're always kind of testing things to try to see what will work, using our knowledge base to guide us. But the reason that I think it's actually fundamentally human-centered design and innovation skills are kind of, they're very close to us as clinicians. So acquiring these skills are typically not that difficult for clinicians because it's pretty foundational to what we do.
Yeah, I mean, my experience of quality improvement is just been that, it's like this superpower in some sense where you learn this framework to actually make meaningful changes in your clinical environment. And until I learned those skill sets, it was quite easy to be a bit, I guess, apathetic and passive around the system that you're in because it is so complex. You are so busy, and it's a very challenging place.
Yeah, it's so important right now, Jono. I mean, if you listen to the way that people are talking about the workforce at the moment in our clinical environments, it's very, beaten down. It's very downtrodden. It's just a tough time right now. We're understaffed in many of our clinical units and locations. People are stressed. They've come through a couple of years of pandemic time, just feeling very low. And all around us are systems challenges, right? All around us. Every day, I'd venture to guess that any clinician that goes to the hospital or spends a minute in a clinic will be able to experience a system problem, almost immediately. Or if you're a patient, you don't have to be a clinician. If you're a patient, you will experience system challenges. And people that are both clinicians and patients or have the experience of being a patient even for a day will see the systems problems readily when you go through a hospital or clinic environment very, very quickly. And when you face those problems, you have a couple choices, right? You can say, these problems are too big for me and I can't solve them. Or you can say, these problems are going to persist unless I do something about them. And when you make the latter choice to say, I'm going to do something about them, you then need a skill set to approach those problems. And as you're saying, the quality improvement skill set is a very useful skill set to solve systems problems. Just as I discovered in Peru, 20 plus years ago, whenever I'm working with trainees now, it's like eye-opening to them to discover that systems are actually mutable, that they can be changed, that they're not done to you, they're created by us, and we can alter the DNA of systems just like we can, in many cases, alter the course of care for our patients by virtue of, small scale testing and learning.
And I'd add to that, often, a lot of hospitals and health systems do have quality improvement teams already. So even just seeking those people out is a great way to just start learning, following what they're doing, seeing what they're reading, all of those kinds of things. Obviously, the IHI website has a number of courses and resources that you can look into.
Yeah, 100% agree. Every hospital in the country will have a quality improvement team. I do think that quality improvement teams, I'll just make this comment, that I think that quality has in some ways become pigeonholed as narrowly focused on, in some ways, what the Joint Commission thinks or does, what we're responsible for quality measures, whether that's hospital-acquired infections or other hospital-acquired conditions. But the truth is that at its foundation, and I just encourage your listeners to think of it this way, quality improvement is simply put a change management methodology. It wasn't even designed for healthcare, right? It was designed for other industries, automotive industries, the airline industry, other things. And it's being applied to healthcare in actually a fairly narrow way. But you, listener, can use this method, this simple change management method, for almost anything in your life, whether it's training to run a marathon or, trying to get your kids to school on time or get your kids to bed on time, or taking something in your clinical environment, like a scheduling problem or a waiting time for your patients or otherwise, and making that better. So I just want to encourage you to think about quality improvement, not as the thing that is focused on preventing a central line bloodstream infection, and that's the only thing we use it for, but rather as your method. Think of it as your method for creating a system change. And that system change could be anything that is bothering you right now about how the system practices or behaves, whether that's inequities, whether that's patient safety problems, whether it's waiting times, whether it's your own clinic schedule. It doesn't really matter what the problem is. This method can help you actually solve for any problem that you're facing.
I'd love to go back to a comment you made earlier when you're at Partners in Health around scale, because I'd be interested to hear your perspective of quality improvement and how some of the challenges that people can have and maybe ways to overcome some of the challenges of scale with quality improvement.
So scale is probably, alongside of sustainability, one of the biggest challenges that people experience in any kind of health system transformation effort. And there's a couple ways of thinking about scale, in my view. One is you've got to have the right set of changes, and the changes have to be simple, observable, measurable, types of changes that are clearly register as being an advantage over this current situation. So in the case of drug-resistant TB, treating drug-resistant TB was clearly an advantage to not treating it, right? Not treating it meant patients would die within some time frame. Treating it meant that you gave them a chance at cure. Not 100% successful every time, but in the vast majority of cases, 80+% of the time, we were able to successfully treat patients. So you have to, what is the nature of the change? Is the change going to create an advantage for your patients or your community or otherwise? What's the nature of the system in which you're deploying this? Is this a system that's ready to adopt the change? Is it a system that's going to be resistant to adopting the change? In our case, again, we were dealing with a World Health Organization that was resisting the change, a Peruvian government that didn't have the change listed in their treatment guidelines, and clinical environments all over the city and country that were unprepared to treat this condition. So we had actually a fairly resistant environment in which this change was going to be deployed. So what's the nature of the change? What's the nature of the system that you're trying to deploy it in? And then by what method will you improve the system or the change? And that's where the quality improvement methodology comes in. Iterative cycles of testing and learning to try to figure out how to change the system to become more adaptable to the change. Team 42, that team I described earlier, we had to figure out our way. Team 42 didn't initially exist in our system. We had to realize that there were so many Ministry of Health or government-related barriers that were preventing the teams from adopting the changes that were necessary. They had to create conditions that would make it possible for the clinicians in other locations to adopt the change. They had to rewrite the guidelines. They had to make it easy to obtain the medicines, et cetera, et cetera. So we have to have these three things that when we think about scaling anything: is the change workable? Is the system ready for it? Do we have a method for change, either the specific initiative or the system itself? Once you have those things in place, then you need a way of doing it. And so for us, I'll give you a totally different example that's a lot more recent. Some years ago, now in 2015, 2016, we had an experience with a group of geriatricians. So this is here in the U.S. We had Terry Fulmer, who's the president of the John A. Hartford Foundation, came to IHI and said, we have a problem with scaling up better practice for older adults. evidence-based geriatric practice exists. We know how to treat older adults, how to make them healthier, how to, not only extend their lives, but ensure a higher quality of life. We've been researching this for 3 decades. We have lots of really good practices around this, but we have not reliably reaching every older adult in the United States with this formula for what it would take. So we went to the literature, and she was right. There were 17, evidence-based practice models, randomized controlled studies that documented how to make care better for older adults, whether they were inpatient, outpatient, whether they experienced mobility and functional declines, or they had medication and polypharmacy issues, whatever it was, there was all these kind of methods available. When we went to a health system and we asked them, this is Kaiser Permanente, we asked Kaiser, how many of these 17 practice models are operating in your system today? They described, when they went to do the survey, they found that 14 of them were active, but all of them in little pockets all over the system. None of them linking up into the kind of scaled effort to improve care for older adults. When we surveyed nationally how many of these practice models were in play, we found that of the total number of older adults in the country, only about 5 to 7% of them were receiving care associated with one of these models of care. So a very small proportion of the older adult population was getting the best in evidence-based care. So we then worked on creating a simplified model. And that model was what we call the 4 M's: knowing what matters to the older adult, focusing on medications, mentation, or delirium, dementia, and then mobility, the functional status of the older adults. We call that model the 4 M's. And then we created mechanisms for scaling it, partnering with the American Hospital Association, with the Catholic Health Association, with numerous state health associations across the country. We started scaling with CVS, with Minute Clinics, with the Veterans Administration, where a number of older adults obviously get their care. Throughout the enterprise across the United States, we started working with these organizations. And now over 3,000 clinical locations, hospitals, clinics, retail clinics, or otherwise, use the 4 M's as the basis of how to provide care to an older adult patient. And by our count, millions of patients now are receiving care consistent with the 4 M's of better geriatric practice. And now we're moving into the latest stage of scaling, which is to ensuring that policy, and policy and payment aligns with the 4 M's. And so that's kind of what I think of as when I think about scaling is there's always an innovation phase defining the 4 M's in the case of age-friendly. There's a scale-up phase where we go from, a few sites doing this to thousands of locations doing it and millions of patients getting it. Now to the third and last stage, which is embedding this permanently in policy and in payment so that we have a durable model for success for essentially forever. And that's kind of a combination of spread and sustainability at the last stage. But that's how we approach and think about scaling.
I'm glad you brought up the sort of systemic change that needs to follow on from some of these types of things. I guess I'd love to hear from you about how potentially other organizations or individuals can enact that kind of policy or systemic change outside of a group like the IHI.
It's such an important thing to think about. I mean, policy and it's such a critical aspect of how we, need to think about bringing about sustainable and systemic change. It's an unbelievably powerful lever, both for good and for bad, right? On some level, it can work to help with scaling effective practice. It could also be a big, obstacle, as we found in that program in Lima so many years ago. Ineffective policy or uninformed policy or non-evidence-based policy can also be a major barrier to progress. So it's an unbelievably important thing to consider and to work on. Again, when I think about that multidisciplinary table that we started our call with here, our conversation with Jono, having people that are experts in thinking about how to address policy issues that might be present are so valuable, especially in late stage change efforts, where we're trying to think about how to really change the environment going forward. We're working right now on a national health equity agenda, and through something that we call the Rise to Health Coalition. And this is a partnership with the American Medical Association, the American Hospital Association, America's health insurance plans. So it's several pharma companies, as well as with government and regulators. And, critical to this is the notion that putting all parties around the table to try to come up with essentially consensus practice guidelines so that we can help policymakers make informed policy decisions that will help support the creation of more health equity on an ongoing basis. And that's going to be a vital part. How policymakers respond to that is going to be really critical for us in terms of whether we can create durable, more equitable care systems in the future. It's an absolutely central part of almost every large scale, certainly national change initiative.
I wonder if we could just shift track just a little bit and talk about your current role and your experiences going through transition, so potentially transitioning into this role. And what is it like for you to take on this incredible leadership position?
Thank you for asking the question. I think there's always a difference. I was within IHI. I was the Chief Innovation Officer before taking the new role of being IHI's President and Chief Executive a few years ago now. And, coming from within an organization, I think you have an advantage. You know kind of where the opportunities lie for significant improvement and change. But you also have to recast yourself as the leader of the organization and not another senior person in the organization. So I think there's a bit of it comes with advantages, but it also has some disadvantages in that sense. But in general, I think that, when you think about transitions, I think about you return to what you value, what you are trying to accomplish. And I think of, what am I trying to accomplish here in this time as being like, what do I want this time in leadership to be about? I'm not going to have forever in this job. So what do I want to make this time about? What do I want, to try to affect differently? And for me, that's the major thing that I've been working on for the last couple of years has been trying to make the quality improvement and the quality management universe really center equity as one of its ambitions and one of its goals. And in part because that's important to do, and it ties in with all of the things that you've heard me talk about from earlier in my career. But also because of this fundamental fact that quality improvement as a methodology was designed to reduce undesired variation in systems. It was designed to improve reliability of systems, whether it's manufacturing assembly lines, making them more reliable and reduce variation in those, reducing variation in how aviation instrumentation was or how we fly planes, reducing variation in how NASA builds its spaceships, or otherwise. That's foundational to the method. And by the way, quality improvement has driven all of those prior industries to the kinds of reliability successes that you see regularly in the news. So therefore, for me, quality improvement is actually very good at reducing variation, and equity or inequities are variations that are unjust, unconscionable, actually very costly to our systems, and something that we can change, just like we can change the variation that's present in other kinds of systems. And so for me, the big, one of the things I came into this job trying to do was trying to connect the dots around quality and equity and make sure people saw that as being critically important. I also wanted to help make IHI the place to go for large-scale change. I wanted us to be seen as the place to go when you had a problem of evidence to action mismatches, where the evidence was obvious that we knew how to take better care of older adults, where the evidence was obvious that hospitals and health systems could do something about climate change, where the evidence is obvious that we can do better with sepsis, for example. I wanted to be the place that people would come to help build national initiatives, at the scale of the whole country, where we could start tackling those kinds of problems overall. So, and I think we've been successful at that. We're working on health equity at national scale. We're working on patient safety at national scale. We're going to be working on climate and health at national scale. And we're working on this problem of aging at national scale. So I'm quite pleased that we're becoming represented as this kind of organization that sees the whole picture and how to take ideas from what we know works to everyone doing it reliably everywhere. And that's, I think, the other major thing that I wanted to try to accomplish in this role. So these are I think as you make these transitions, think about, what you value and what you're here for. And always return to those ideas as you kind of lean into your leadership role. The last thing I'll say is this is a time for a different kind of leader. I think we used to have people who were obviously very talented, very bright, high IQ, whatever. And then we had people that were a combination of intelligent, but also curious. And my predecessor, Maureen Bizignano, calls that CQ, curiosity quotient. But I think today's leaders need to have a third dimension, which is empathy. You need to be intelligent, you need to be curious and innovative, but you also need to be empathetic because your workforce needs you in a different way than I think leaders in the past were needed to show up for their workforce. Work and life are very blurry now. People are working from home as they have been for the last couple of years. These boundaries they're not very well defined. And so being an empathetic leader during a really challenging time for people is I think a critical dimension of what your leadership should look like.
Thank you. And I just want to bring back to one of the comments you made around equity and inequity being really costly. I think, as clinicians, we really need to underscore the moral feature of that. Too often, that is kind of grouped in with the financial parts, which is true. But I think we can actually stand our ground on holding those values true on moral grounds as quite strong ones to stand behind.
Yeah, we can do both. I mean, it's you can make the argument many different ways for why the system needs to be different. Whether it's true financial cost, better quality is less costly. Better or more equity is less costly. There's estimates that show that we lose $320 billion a year to inequity. I mean, that's a lot of money, and something that's readily correctable by the kinds of things that we've been doing. So, not only is it morally unconscionable, and you can make that argument. Not only do we lose a lot of human lives, you can make that argument. Not only is it the right thing to do, you can make that argument, but it's also costly. It's also very financially costly for our system to preserve the kinds of inequities that we have in our system.
Now, as we're coming to a close, I just wanted to ask a couple of quick questions around how you are able to keep growing and keep having these types of experiences and not burn out and make sure that you're looking after yourself.
Yeah, it's a great question. I get asked this question a fair amount actually these days. So I think there's a lot of empathy for leaders too at this time, and I'd express that empathy for leaders as well. I think it's not only a tough time to be a frontline healthcare worker, but it's also a tough time to lead systems because you're up against some things that are pretty challenging, and there's a lot of demands on you as a leader to as I just said, be empathetic and curious as well as lead your systems with intelligence. I think, you've got to find your places that you connect and you recharge. For me, that's a combination of my family who are incredibly supportive and wonderful. And, being outside, being in nature, as I drive into the mountains or something for a weekend trip with the family, I can just feel the stress decline as I'm heading off on a Friday afternoon. I can feel that experience very clearly. And it registers for me. And I think that's a thing that people have to do, but also enjoy what you're doing. And if you're not enjoying what you're doing, don't do it. Honestly, there are lots of choices that we make every day. I love what I do at IHI. I love the challenges that we have, that we face, the problems that we're willing to take on and lean into. And, I think I love the fact that we have no lack of ambition when we're trying to tackle a big problem. So, trying to solve the problem of creating better care for older adults, trying to solve the problem of health equity, climate and health intersections. These are all big problems, and that keeps you kind of curious and keeps you working and keeps the innovation spirit very high, which is the part that I love the most.
I really like that in terms of recharging with the basics truly working. And I think the other piece here is around passion. And it's okay if your passion changes. It's okay to move on then if your passion goes away. That's fine. My last question for you is there any advice that you would give your younger self if you reflect back on your career?
I feel very fortunate in what I've been able to, have the opportunity to do. And I feel like I've really loved what I've done all the way through my life. And so, I would give myself and any version of my younger self the advice to keep pursuing the things that you really love doing, because it'll lead you to where I am at the moment. Also, I would give my younger self the advice of maybe experiment a bit more. I think I think it's a good thing to try to tackle new things periodically on a regular basis. Try to challenge yourself. Try to learn about some new things, new levers, new opportunities that might face you, just to broaden your tool set. As suggesting to all of you who are listening here. But that's, I think, a critical dimension of all of this.
Before you go, I understand that you've got your own podcast.
It's called Turn on the Lights. The idea behind this podcast is that we know there's a lot of things about American healthcare that's very confusing, that's almost deliberately confusing on some level, that's hard to understand, opaque. And we want to try to dig in on some of those issues. Why do medicines cost what they cost? Why does a hospital bill so expensive? Why is CVS buying Oak Street Health, right? What's going on with private equity in healthcare? Some of these things that most people don't really have a lot of clarity or insight into. We're trying to help, as the title of the podcast suggests, turn on the lights on some of these facets of American medicine that are hard to understand. So I hope you'll join us at Turn on the Lights at some point.
Brilliant. Sounds fantastic. All right. Well, thanks so much and take care, Dr. Kedar Mate.
All right. Thank you so much.
And that brings us to the end of the podcast. If you want to go deeper about any of these topics or join the discussion, visit our website, clinicalchangemakers.com. Now, one small ask. This is a brand new podcast, so if you enjoyed our work, please rate us and share it with your friends and colleagues. It really helps. Until next time, take care.